So what's been going on there in England? How's everything out there?
Well, England continues in its old ways of not really having a clear direction of what we are going to do, and which is such a pity. We have a government here which is, of course, doing its best, but it could do a lot better. And my feelings are that people are getting fed up of changes, procrastination, changes in direction. 1 minute it's a no, another minute it's a yes. And that drip, shifting in positions, etc., is making people lose faith.
Now, I understand we're having the same issue here in the United States.
Indeed.
Yeah, 1 minute get a vaccine, then you don't have to wear a mask. Then it is, you get a vaccine and then you still have to wear a mask.
Yes.
And a lot of mixed messaging, which then confuses a lot of people. So let's talk about, since we have you here, let's talk about common misconceptions of COVID-19. And something that I want to really discuss is, if you have a vaccine, how safe is it for you to be out and about? Should you be wearing a mask? Should you not be wearing a mask? Are you able to still transmit COVID-19 to somebody else? Let's talk a little bit about that.
Yes, thank you, Sheila. Always a pleasure to share knowledge with yourself. So we must celebrate and salute the scientists and the engineers who have made possible the invention of vaccines that work. And I really mean it, vaccines that work. And the vaccines thus far work, and they work very well. What the vaccines do is they prevent your body from going into a hyperimmune response when they encounter the virus and start damaging your body such that you end up in hospital needing a ventilator and dying. So that's what the vaccines do. They prevent you from getting severe illness, no more, no less. This is a really important issue people need to understand. They prevent you from getting severe illness in 95, 98% of cases, not 100%. Nothing is 100%. The second thing that they do not do is create sterile immunity. And what we mean by sterile immunity is once you're immunized, you don't get infected and you are not infectious and you remain immune for a very, very long time. Unfortunately, these vaccines have not been able to achieve that. So what that means is, although you are fully immunized, you can still get infected. And by being infected, I mean clinically infected, meaning you may have some signs, you may have some symptoms, and you may have a mild illness, or you may have a severe illness in some cases, but usually it is mild or moderate illness, not severe enough warranting hospital admission in most cases. So if you are infected and infectious with your mild to moderate illness, you can also be infectious. So a fully immunized person can also get infected and be infectious and infect other people. So that's where we are with the current state of play with the vaccines against SARS-CoV-2.
Now, the people that are vaccinated, do they have a higher viral load or less viral load than the people that aren't vaccinated as far as spreading goes?
Yes. So if you had asked me this about 3 months ago, I would have said the viral load coming out of a mildly, moderately infected, fully immunized person is much lower. Unfortunately, recent research seems to indicate that the viral load is just as high as if you were not immunized. So that's something which is unfortunate, because I would have said that that was another reason to be fully immunized, which is you're less infectious. But unfortunately, your infectivity is not decreasing. because you're throwing out just as many virus particles. But then in the scheme of things, I would like to challenge that statement, and I would like to say it as follows. Who has actually precisely measured viral loads from a fully immunized person? It's very difficult to do. The second thing is that the duration of illness in a fully immunized person will be shorter. So if you are ill for a fewer days, fewer length of period, then you could also surmise that you will be infectious for a shorter period.
The issue then is those that have the antibodies or the immunity that's going to be wearing down, right? Like say the elderly or the immunocompromised, even though they are vaccinated. At what point do we know, okay, now now they're more susceptible? Because there are a lot of people that are double vaccinated, even the elderly. I see them with my patients all the time, walking in, no mask. They're like, oh, I'm vaccinated. And part of it, I feel, is the media is not really giving that correct messaging that you still have to be protecting yourself, right? And yeah, it's not enough on the educational front of what we need to do to protect the elderly, to protect the immunocompromised, because we can't really measure antibodies level to see at what level do you need a booster, or maybe you've had natural immunity and you're okay. So can you comment a little bit about that, Dr. Bharat?
Yes, indeed. And again, these are such difficult concepts for people to grapple with and understand and truly understand. Even my medical colleagues don't fully understand it. So it's not surprising that members of the public find it all confusing. So we also know that one of the effects of the vaccine is that its immune potential starts to drop off with time. But we do not know how much it drops off by, and at what stage, the tipping point, one needs a booster to reboost your immunity. These are unknown unknowns, because immune systems don't work on the measure of I found so many antibodies per milliliter in your blood and therefore you're immune or not immune. It doesn't work like that. So it's an unknown, and only time will tell us as we go through having immunized people for over a year, and now they're in their second year, etc., how much of that immunity is really dropping off. Is it dropping off like a stone? Is it gradually going down, etc.? It's an unknown, and so we don't know. And I'm sure, Sheila, your next question to me is going to be, at what stage should we give boosters? And I'll answer that for you before you ask it to me. And my answer is, scientifically speaking, at this point in time, I wouldn't go down the route of wholesale booster vaccines for everyone. If I had to, I would selectively immunize the extremely vulnerable people who've had the vaccine, say, a year ago, for boosters. That would be my rough measure of, clinically extremely vulnerable after a year of having had their vaccine, give them a booster.
Yeah, the immune system is so complex because even if you don't have antibodies, you still have T cell immunity and memory B cells, which are kind of holding that memory of your infection or your vaccine. And then if you get infected again, they will then produce the antibodies that are needed to fight off the infection.
That's right, Sheila, absolutely right and spot on. And therefore, a measurement is completely irrelevant, a measurement of antibody levels, because you may not detect any. On the other hand, you've got such good T cell, B cell memory that as soon as the virus particles are detected by your immune system, they go into surge production of antibodies, and they make lots of antibodies in a very short time because they have been primed And so on the one hand, you had very little there, but your T cells, B cells recognized it, and they produced a flood of antibodies as and when required.
So where are we as far as testing for these kind of things? Are people working on being able to look at T cell immunity tests, for example?
I don't know is my short answer, but looking into the biology of it, I think it would not really be very helpful to say, I want to find a blood test measuring T cell, B cell memory, because how do you do that? Do you do some bone marrow and you take some specific T cells and then challenge them? It would be a complex test to do, and the rough and ready test is available, and I recommend don't do it. People are often asking me, oh, should I go and pay some money and have some antibody tests done? And my answer is no, because I don't know what the precision for this test is. And secondly, how much informative it is, we don't know. And remember, the tests that are present at the moment only look at antibody levels. We do not have tests which specifically target and see if your B cell memory and T cell memory is wonderful and that it will respond in time and respond and produce lots of antibodies. We don't have such tests as yet.
I'm sure someone somewhere in the world is working on that.
I'm sure.
The people that you're seeing that are doubly vaccinated in hospitals, what does those demographic look like?
It's funny, literally minutes before coming on to this program here, I was just looking at something, and the vast majority of people who are admitted to hospital, and I mean by a large margin, the vast majority of people admitted to hospital are unimmunized or underimmunized.
And the under-immunized, could that still also be people that are just elderly that maybe had their vaccine a year ago? What are we seeing in the hospitals right now?
No. By under-immunized, I meant not fully immunized. So they would only have had one of their 2 jabs. So by and far, what we are seeing is mostly unimmunized people. Of course, we are seeing a few fully immunized people as well, but by far and wide, the majority are not immunized.
And out of the not immunized demographic, are you seeing, like before it used to be more of the immunocompromised, the elderly? What is the demographic there that you're seeing now?
Yeah, again, it's the usual picture, but we also see under-immunized younger people. So the elderly, vulnerable people tend to be in the brackets fully immunized, and therefore we are not seeing them. Then, nevertheless, there are some clinically extremely vulnerable elderly people who probably didn't make full immunity, and we see them, but they're very, very few. So the demographics are the younger people who are under-immunized or not immunized.
Got it. And are you noticing a shift in the symptoms that are developing? I was recently reading an article that was saying that there are more, the symptoms are coming across now as more of the 77% runny nose, 74% headaches, sneezing at 67%, sore throat at 52%, loss of smell at 52%. Are you noticing there's a shift in the symptoms that are coming in?
Yes, indeed. Yes, indeed. And here we sort of concur that it is a moving field. And what we started off with before, which was a dry cough, headache, myalgia, shortness of breath, difficulty breathing, etc., has gone on to now change with, as you say, loss of smell, taste, sneezing, cough, not necessarily a dry cough. So yes, we are seeing all those signs and symptoms that you've just described.
And this is vaccinated and unvaccinated?
Yes.
So suddenly we've just had a shift in symptoms. That's kind of interesting with this virus.
Yes, it is. It is. And it's difficult to explain it away. But one way to explain it away is with the variants, it is obviously showing that once upon a time, they infected the ACE2 receptors higher up in your respiratory tract, etc. And now the variant, which is just a slight change in its structure, slight change in its makeup, it may also be setting up initial infections lower down in your respiratory tract. And with that, the change in signs and symptoms.
Okay, that makes a lot of sense. Are you finding the Delta is more fatal than the Alpha?
No, it's not a case of it's more fatal. However, without a doubt, it is more infectious, and it is more infectious to the order of 6-7 times. So it is 6 to 7 times more infectious. So now we go on to that concept of what does more infectious mean? So I was avidly listening to Professor Ranjit's presentation, and what it means is you will need fewer virus particles to set up the same infection in a human being. So usually you're assaulted by a few thousand particles, because remember, these are nanoparticles, they're tiny, tiny, tiny. So if you were thrown 1 or 2 virus particles, it's highly unlikely that you will get infected. But when a few thousand come your way, that's what we call a infecting dose, then you will get infected. But with with Delta, with Delta, you need less of them because it is more infectious.
What was interesting with the talk that we just listened to from Professor Rajneesh was I didn't realize how long the viral particles could actually be suspended in the air, like 5, 6, 7, 8 hours, which reminds us that that's a long time. So if you walk into a room where you have had somebody exposed, 7, 8 hours later, you could still have particles there that you're breathing in and infecting you.
Yes, so what he was also describing are suspension and then resuspension. So you may have viral particles which settle on surfaces, and if the surface, if the humidity in the room is such that it still keeps the virus particle alive, so it has settled in the room, but then it is resuspended, and it remains airborne, or it is re-airborne in a room from dry surfaces like your table, chair, etc. So yes, this concept of closed indoor spaces are dangerous, especially if they have lots of human beings. So closed indoor places need a lot of ventilation, meaning fresh air. So what fresh air does, basically, is if you've got millions of those particles, invisible particles, like say dust as he described it, floating in the air, and you have a large draw of fresh air coming in, then those millions of particles get per given volume, yeah, so they get diluted. So they become, say, 100 per liter rather than 100,000 per liter. And as you dilute the virus particles, the supposition is that you dilute it sufficiently so that you don't get infected, so that you don't have a infecting dose in that room at any one point or at any one place in that room.
That makes sense. So what I'm hearing you saying is if you have a few particles, your body can probably fight it either naturally or it can recognize something's wrong and mount a response. But if you have a huge dose, your body's overwhelmed, and that's where it's got a chance of taking over.
Correct, Sheila. You're absolutely spot on. And that is the issue. So we don't want you to have a loading dose. We cannot create a sterile environment whereby you will not encounter any virus particles. That is so difficult, it's almost impossible to do. So what we do is we dilute it, and we dilute it by an intake of fresh air. And by having an intake of fresh air, we reduce that potential loading dose of 100,000 virus particles to 1,000 virus particles. And that 1,000 particles is hopefully low enough for you not to get an infecting dose.
Yeah, and everyone has a different infection dose, right? Like some people, they can still be sick but not be so infectious, and some people can have a very, like the super spreaders, for example. Can you explain what a super spreader is?
Yeah, sure, Sheila. Most of us are infected and infectious. A super spreader would be somebody who generates more than the average number of new cases. And that super spreader can be something due to their behaviors. So there may be someone who is infected just at the right time, who may be secreting a lot of virus particles, who hasn't got any precautions like wearing a mask, who's sneezing and sneezing aloud and talking aloud, singing aloud. All of those types of people can be super spreaders, because what they're doing is behaving in such a way that were they to be infected and infectious, they would create a lot of cases. So, singing at the top of their voice, sneezing without any precautions, not wearing a mask. Having said all of that, there is also one special category of person who you could say has a potential to be a super spreader. That one person would be somebody who is infected, is infectious, and is immune suppressed. So that immune suppressed person will have a rip-roaring, raging infection, and they would be pouring out billions of virus particles because they are so immune suppressed that their body is just unable to fend for itself by making antibodies and T-cell interventions, etc. So they are releasing a lot of virus particles, and that's a super spreading event. But by and large, any one of us, this is the important bit, could be a super spreader if we have certain behaviors. And I repeat again, and those certain behaviors that make us a super spreader are in a closed, poorly ventilated place. We are talking loudly, we are shouting, we are singing, we're not wearing a mask. We have, dirty hands from having sneezed into our hands, and we're going around contaminating surfaces as we walk around. So any one of us can also be a super spreader if our behavior is that way.
And you can still be a super spreader if you have no symptoms. Is that correct?
Of course. So you may be, this is why SARS was easy to control, because the one critical thing with SARS in 2003 was just before you became infectious, you spiked a large temperature. So your temperature went over 38 degrees centigrade, and then a day or so later, or half a day later, you became infected and infectious. With SARS-CoV-2, unfortunately, you can be without symptoms. So that's the thing called asymptomatic. In other words, you are perfectly well, you haven't got any of the signs and symptoms that you would normally associate with the infection, but you are spreading your viruses.
Wow, which reminds us the importance of wearing the mask indoors and in certain situations outdoors, because that's working as a filter to prevent any of these virus particles coming in.
Yes, indeed. And even if the mask is not absolutely airtight, which they usually are not, what you're doing is reducing the number of particles coming out of your nose and mouth. You're decreasing it. You're capturing them in your mask.
Yeah, we recently had an incident here in the US where a teacher was put his mask down, and he happened to be infected, and he infected his entire classroom. Now, which brings me to the next point, is how comfortable do you feel about kids going to school? Like, what precautions can schools take to for the safety of their kids?
So number one, immunize. And the reason why I jump immediately for immunization is all the other precautions are sort of doable, but they're not really doable. Children sit together, they are basically like the bees in my garden. They huddle up together. You know, I go out to see my bees and I say, nothing different from teenagers and my bees. They're the same. You know, they all huddle around together in their beehive or outdoors if it is a warm, sunny evening. And it's difficult. That's the way children are. So, you know, we talk a lot about, and of course we should, you know, have nevertheless screening and precautions. So where I give advice to schools, I say, you know, you could at the gate be a watchman of, you know, is this child fit to come into class today? Have they got a runny nose? Have they got any signs and symptoms? Have they got a temperature? Have they got anything suspicious that could be an infection? You could test them. I know the tests are not very accurate, but at least it gives you some degree of measure. And you could space the children out in 2 classrooms from 1. In other words, reduce the number of people in 1 class. And you could have forced ventilation, meaning a fan at a window drawing in air and pushing it through the class and out of the other window at the other side. So those are all precautions you can take. None of them are absolute. But faced with all of this, how do we proceed? And my answer is we can immunize. And of course, our learned people will say, but children usually have a mild illness. Why are you advocating immunization? Well, we do the same for rubella in boys. We immunize them to protect a potentially unimmunized pregnant woman from a rubella infection, which can be severe to the child in gestation. We give them the seasonal influenza vaccine. And there is this concept of long COVID. So a child who gets infected and then goes on to develop long COVID may be unwell for 3, 6, 9 months. We don't know. So long COVID is also something very serious, and we can prevent it by taking vaccines. So if you have a highly vaccinated school children population, at least you know that when they encounter the infection, they are unlikely to go on to develop long COVID, unlikely to knock on the GP's door, unlikely to knock on the hospital's door, and unlikely to have long COVID. And then people will also challenge me. So it's better to answer the challenge before the challenge comes, which is, what about myocarditis? And my answer is, yes, there is a concept known as inflammation of the heart muscles following immunization, but that is a very rare event. And the myocarditis is short-lived with full recovery. On the other hand, you could get COVID and give you myocarditis, and it may be a lot more severe with a COVID infection. and inflammation of your heart muscles. So when you do all the balancing things together, what would I do? I would immunize my children, and I have children at school, I will be immunizing them.
Got it. Let's talk a little bit about technology and where are we with new vaccines, with new protocols, nasal sprays. Constantly reading stuff online about new nasal sprays that are going to be more preventative, for example, spraying every few hours, new vaccines that are coming out. What is giving us some kind of hope?
So there's some stuff in the literature which talks about a coating of your mucosal membranes with a spray such that the virus doesn't get a chance to get a foothold. But I reckon this is a temporary measure which probably won't work because the virus, especially the Delta variant, is so infectious. On the other hand, we've got quite a few vaccines in the pipeline that will be coming online in 2022. And therefore, the current shortage of vaccines worldwide will suddenly stop being a big shortage in 2022 when other platforms of vaccines also start to come online. Have I answered your question fully? I forgot all the questions that you were asking in that one question.
No, I was just kind of asking just what the technology advancements were. And as far as the vaccines that you just touched upon coming out in 2022, are they going to be mRNA vaccines or any different? For those that are hesitant to take an mRNA vaccine, are they going to be different kind of vaccines that are out there, more live attenuated ones, more of the traditional vaccines that we've seen in the past?
Yes. So with the mRNA vaccines, the Moderna and Pfizer ones are already out. There is a DNA one which India has deployed, and it will be interesting to see how well it performs. And then there are virus particles which are synthesized in the lab, and then they're deployed. So there are new types of vaccines that mimic the old vaccines that we're used to, and we expect quite a few of them to start coming online in 2022.
So does that give you a little bit more hope, Dr. Bara? Are you excited about all these technological advancements?
Yes, I am. I mean, personally, I'm amazed and impressed with the mRNA vaccines. They're absolutely marvelous. And they're so marvelous that I now feel really good that vaccines for other infections will also be invented, like Nipah virus, dengue fever, tuberculosis, malaria, and also maybe also for cancer therapies and things like that. So I'm really impressed and feel very positive about the mRNA vaccines for their other uses. And of course, it is also good to see the DNA vaccines made in India, the virus particles synthesized in the laboratory, put together and then made into a vaccine. That's Novavax. Yeah. And yeah, it's all good. It's all very good. It's amazing what we can achieve if, as scientists, we work together, we have the funding, we can really improve humanity no end. It really is a shame upon politicians that they don't fund science properly. Because look at it, they were desperate and panicked with the pandemic, and all the gates and all the restrictions were lifted. Gates meaning money, funding, etc., were made available. And in less than a year, we were able to have a vaccine that works.
Yeah, that's true. I mean, even what's happening in the hospitals, when a patient is getting admitted, now things are changing. In the US, they're using monoclonal antibodies, and there's different ways of even treating the people when they come in and giving them a higher chance of success. Can you comment a little bit about what's been happening in the hospitals as far as treatment goes that you're seeing?
Yeah. Yes, Sheila, thank you. Because I forgot to mention that we've also got advances in therapeutics. So our therapeutics that we had was dexamethasone if you needed oxygen support. And at that stage, we gave you dexamethasone and it made a difference to the outcome. Similarly, although it's very expensive, we've seen a positive outcome of using monoclonal antibodies. So what monoclonal antibodies are is that antibodies are made in the laboratory. Monoclonal basically means of one type, yeah, and you know, so we make these antibodies artificially in a laboratory, and as a adjunct to your body fighting this infection, we give you an injection of monoclonal antibodies to fight off the infection. And then there are other therapeutics also under consideration, and they've been there for some time, which are what we call viral blockers. So there would be like oseltamivir, otherwise known as Tamiflu, which basically inhibits a viral enzyme and stops the virus from replicating. So similarly, there are lots of work going on antiviral therapeutics. You take this drug, and when you take this drug, either your receptor is blocked or the virus's spike protein gets coated in this drug, and therefore it's disabled from being able to interact with your ACE2 receptor and infect you. All that work is happening, and no doubt we'll see the results of antivirals as well as monoclonal antibodies, which will get cheaper to manufacture once you're manufacturing it in large numbers.
Yeah, it's always interesting to kind of read up and see what's out there. I see that, you know, Oxford University is doing research. They're looking at pills, and there's so much advancement that I'm going to see probably in the next 6 months or so, I guess, right?
Indeed. And again, it really makes you feel good that we have such clever people all over the world who think the unthinkable and come up with solutions for the whole of mankind.
Yeah, I've been doing a lot of research on even the immunity aspect, that they're now seeing that people with natural immunity have a lot more immunity than they had thought about before. And some countries are even doing like immunity passports as opposed to vaccine passports to see, to allow people to kind of go out and about, showing that they have level of immunity out there.
Yeah, I'm a little bit skeptical about it, because I'd really love to know, you know, what their criteria were for judging that, you know, this is a highly immune person compared to this is a not very immune person, and we want to restrict their movements, and these people we are going to allow. But it's tricky territory, Sheila.
Yeah, so is everything when it comes to this COVID-19. Everything just keeps changing, more concerns and different things could turn up. Are you worried about anything in the future as far as any more of the variants? Are we seeing anything out there in some of the countries that might be concerning us?
Yes, I remain worried, and I remain worried in that we have failed to immunize the rest of the world, and that is such a worry. So most of Africa, Asia, South America, etc., are way under immunized compared to United States, European Union, United Kingdom, Israel. So where you have uncontrolled runaway infections in lots of people, and South Africa is one very big case in point, because again, by mismanagement by the former, not the current, former South African presidents who didn't believe in HIV infections, HIV AIDS, etc., they have created an absolute mess. So there is a huge population who are HIV positive in South Africa. And if they are not really taking proper antiretroviral drugs, etc., they will be immune suppressed. And if they are immune suppressed and they get a SARS-CoV-2 infection, they will have a prolonged, continuous infection for a long time. And in any person, anywhere, who has a prolonged, continuous infection, making lots and lots of cycles of virus replications, it is in those exact circumstances where a variant will arise. And if we have a variant that arises, which is more severe disease causing, it is entirely possible to get a variant which is more severe disease causing. It could be a variant that bypasses the immunity created by the vaccines. So that's also a step backwards. We could get a variant that arises which starts to cause severe disease in children. That would also be an absolute disaster. So there are warnings, there are concerns, there are all of these issues that I, as an ordinary scientist, would articulate to politicians. What do? What most politicians do is hope and pray it doesn't happen on their guard. And that's all they do. They don't say, we need to do something about this. It's a crazy world.
So with the new vaccines that are coming out in 2022, are they going to be much easier storage-wise, cost-wise? So do you feel like this issue with the global vaccination will be addressed, but more kind of early of next year?
It will get better, but it has highlighted the plight of poorer nations that we've always known about. So poor people suffer more, poor people have poor chances in life and in the world. So all that these vaccines are going to do is greater availability and greater number of people therefore immunized. The ones that are really difficult to transport and store are the mRNA vaccines. So the new vaccines that are coming out are not of the mRNA platform, and therefore they will be easier to store, give, supply, etc.
Something that I would like to also mention is just how important it is to use this time now to get as healthy as possible. You know, if you are obese or you're overweight or diabetic, this is the time to really start homing in on eating right, exercising, getting your body healthy, having vaccines and everything, that's great also, but get your body as healthy as possible. You know, make sure you're getting the vitamin D, you're out there, if taking supplements as necessary, that if your body is depleted, like zinc, vitamin C, eating right, eating a lot of fruits and vegetables. Is there anything else, Dr. Parrott, that you'd like to add to our wonderful global audience out there?
So, no, Sheila, you're absolutely right, is get healthy, remain healthy, not only for COVID protection, but for cardiovascular health, cerebrovascular health, etc.
Thank you. Is there any closing remarks you'd like to say, Dr. Parrott?
I want to reassure people that we will move on from SARS-CoV-2 one day. Things will get better. I don't want you to sit there feeling, you know, your world has ended. It hasn't ended. We're going through a very traumatic time. And because we're going through a traumatic time, I ask you to come with us, which is remain happy, do everything you can to be happy, sleep well, eat well, exercise well, remain infection-free. And I look forward to seeing most of you alive and well. And we will look back to this and say, wow, that was a journey. Things will get better. So don't be of gloom and doom, be positive, and look forward to things getting better. In the meantime, keep well, keep alive.
Wow, that was a wonderful closing remark. We do have to stay positive, do have to be grateful, practice gratitude daily, have a positive attitude on life, because that all makes such a big difference with our immunity. It helps boost us up when we're
Absolutely.
feeling better, right?
Absolutely. Yeah. And positivity is very important. So if something is getting you down, try and avoid it and just focus on good times are not that far away. We've been through this for 20 months or so, and just keep going a little bit longer, better times will come.
Well, thank you, Dr. Barra. It's always such a pleasure to have you on the show, and I look forward to seeing you on all the other channels and CNN and BBC. Every time I switch on the TV, it's such a pleasure to see you and the wealth of knowledge that you share with us.